If you could get in Judy or Sumit's ear and say, look, you're dropping the ball on pushing or developing one thing, where would you direct Epic's development efforts?
Would have to say voice.
Can you elaborate a little bit on what that means to you?
Yes. Imagine Siri that wasn't awful, that worked with Epic.
So the place that I would like to see them work on is, imagine if you could put into an internal Epic system, an LLM, where you could just say, I want to solve this problem. Here are the parameters. Give me some potential build and some configuration.
That's exciting. If I can push that further, so it's maybe a pipe dream. But if I can look into our own system to say, and you need to be on this upgrade level, or you need to have had this configuration, and you've deviated from foundation, you need to bring this back to foundation.
Yes, and if you could literally say that stuff out loud with voice, it would be amazing.
Exactly. Yeah.
Welcome to Beyond the Blueprint. My name is Craig Malkery. I'm the Managing Director at Spyglass Consulting, and I'll be hosting today's panel discussion focused on a retrospective of the Epic EHR. This episode is part of our collaboration with AMDIS, the Association of Medical Directors of Information Systems. Well, today we're talking with three health IT leaders who are deeply involved with their organization's Epic deployments and digital transformation. Our esteemed guests today include Dr. Roy Esaki, the Chief Health Information Officer at Queen's Health Systems in Honolulu, Hawaii. We have Dr. Yaa Kumah-Crystal, the Health IT Clinical Director and Associate Professor of Biomedical Informatics at Vanderbilt University Medical Center in Nashville, Tennessee. And we have Dr. John Lee, President of HIT Peak Advisors and the former CMIO at Allegheny Health Systems in Pittsburgh, Pennsylvania. With that, why don't we go beyond the blueprint? The Epic EHR is the backbone of health IT in America. It's deployed at more than 1/3 of all U.S. hospitals, supporting more than 250 million patients. A typical Epic installation costs more than $100 million and takes 2 to 5 years to implement successfully. According to KLAS, though, 30% of Epic installations face major delays, exceed allocated budgets, and cause months of disruption after launch. John, if it's okay with you, I'm going to lead the first question off for you.
Sure, absolutely.
Hospitals spend a lot of money on Epic, but many of these projects still fail. What leadership mistakes cause these problems? And perhaps you can share a brief story.
So one of the things that I reiterate many times as I talk about this sort of stuff is I use the Navy SEAL saying, slow is smooth, smooth is fast. And you'll hear a lot of that kind of repeated theme of get the foundation and the basics done right, and then everything else kind of flows from that. The problem is that to do it that way, you do have to go slow first, and you have to be methodical. And sometimes that does chew up a lot of time on the front end. So a lot of times organizations will skip out on that because they have this compulsion to just move ahead and get the stuff in, just get Epic live, and we'll worry about the other stuff later. Unfortunately, a lot of times you don't get to that stuff later, or you've put in things in such a messy fashion that it's really difficult to unwind. So a simple example that I have is that I remember we were doing some analytics and decision support based on certain types of medical specialties. And one was ENT physicians. And so we're using some of the metadata around the Epic provider record. And I was dismayed to find that we had 4 different ways that we actually displayed head neck or tagged as head neck surgeons. ENT, head neck, otolaryngology, and otorhinolaryngology. So basically it was this is a small paradigm of what happened, that people were just in a rush to get a new ENT physician into the system. They added whatever specialty that they wanted. If they didn't find one, they just created another one. And yeah, it got that ENT physician in right away, but it created a mess downstream. And then that sort of issue was repeated multiple times over multiple specialists. And that same sort of theme can be repeated multiple times when people talk about, say, data governance. One of the things that people often talk about is like length of stay. what is length of stay?
John, let me get
Sure.
Roy and Yaa involved here. Roy and Yaa, many say the Epic EHR is too complex to use well. In your experience, complexity the real problem, or are hospitals not making the necessary cultural and process changes required for a successful deployment?
Why not both? We can throw blame around everywhere. I think there's definitely an element of complexity in Epic where the legacy product, which is evolving, they've gone to hyperdrive, et cetera, but was very much a stereotypical copy of paper records. And I think that's, the main thing that informaticians rail about when we have experienced the transition from paper to digital. So we're improving, but there's still a lot of just paradigms of searching for information where you're going to a tab, and then you're going to the information in the tab. You click on that information, it's a separate print group, and just the foraging that you have to do is just not a good user experience. It doesn't take advantage of the fact that you have a computer that is powerful and can do more beyond what a manual process of searching is. They're looking at ways to move in a smoother direction, but certainly that's just been a challenge and required a lot of training, because there's some tools where you're not having to teach people how to use the device. It's just more intuitive. But with the way that things have been set up in the EHR, it has not been that way with regards to the way we've been trying to teach our patients. With regards to how the hospital implements things in the governance processes, I think that's a huge part of it as well. Documentation is one of the areas that I work in that's been just a huge burden for providers in general, but not just because writing notes is hard and annoying, but because there are all these regulatory considerations you have to take into account in writing a good note. If we could blow it up and start again, I think documentation would be a lot smoother if you just have to say this is what I think and this is what happened, this is what changed. But you can't just do that, because in order for the hospital to get paid, you have to check off all these boxes, figuratively and literally, but and answer specific questions and put things in a specific order. And that misses the point of medical communication.
Let me get Roy involved. Roy, what are your thoughts on this topic?
Yeah, so you mentioned Epic's complexity. It absolutely is complex, and we hear this all the time from private docs who are transitioning from more lightweight systems. But I think that really mirrors the reality of modern healthcare, with documentation standards, billing requirements, regulatory quality needs. The system has to support a lot of moving parts at the highest level. So I think we flat out acknowledge that root cause. And that said, the biggest challenge Epic implementation is change management. Implementing Epic or any other EHR isn't an IT project, and we all know this, but I think all the organizational parts need to recognize that it's that partnership between IT, informatics, and operations, with that clear governance that you just mentioned, willingness to reimagine workflow, standardize from the ground up. When you try to layer the new technology on top of old bad habits, it creates more problems rather than solving them. So I think recognizing that part.
Can I touch on the subject of change management, documentation, and doing things the old way?
You've got 20 seconds because we're going to pivot to the next topic. Go ahead, John.
Okay. So doing things just in the way that we've envisioned them on paper is not the right way to do it. You can actually do this documentation of all the little checkboxes and quality stuff and shuffle them off into a hidden part of the note that we can now do electronically and still have a much more readable note, but still fulfill all your regulatory requirements. That's an example of one way we've failed to actually fully leverage the electronic system.
All right, guys, we're going to pivot to the next topic. Roy, don't get too comfortable. We're going to talk about technology, how Epic's integrations are helping or hurting progress. Roy, hospitals add third-party apps to the Epic system to drive innovation and improve capabilities. Does this approach work, or are we causing any unintended consequences? What risks might hospital leaders overlook when trying to integrate these third-party apps?
Okay, so on paper, it's basically a decision between the best of breed and best in class. And sometimes plugging in that third-party app may be the right move, but it comes at a lot of costs. Right? It fragments the workflows and adds integration problems and has overhead. Moving outside the Epic ecosystem, you lose that benefit that comes with the unified platform. Especially as Epic evolves its native capabilities. And I'll share one specific example at an organization that I struggle with to this day. We implemented a third-party solution quite some time ago, before Epic Secure Chat was available. And it's been valuable. It's accessible to non-clinical staff and serves as a parallel redundant system for downtimes. We're relatively stuck with it, and we're missing out on the tighter integration that Epic now offers with embedded messaging and in-chart communication. So, it's something to bear in mind about where Epic is now and will be in the short-term future. Epic might not be the best right now, but the strength might be worth it down the road.
I see you're excited, Yaa. Why don't you jump in?
God, absolutely. Especially what you were mentioning about messaging, because we're in the same boat. The best of breed versus best in class. Build versus buy is another consideration, especially if you have a department that's able to configure their own tools. Technical debt. Because that's what the problem we run into whenever we try to implement third-party solutions, even if they are definitely better than what Epic offers in the vanilla foundation system. It becomes like a not my monkey, not my problem situation, because like if anything breaks, then it's like, oh, is it the vendor? Is it the API? Is it Epic? Whose responsibility is it to get everything working again? So we really have to think critically about how much debt we're willing to incur to be able to support this accessory system, and what the long-term strategy will be. So before any of that, you need to have discussions about Epic, about where they're going, what's on their roadmap, and other organizations that have tried it to determine whether it makes sense or not.
Great comments. Sean, do you have anything you'd like to add here?
Yeah, I think just generally speaking, I think Roy and Yaa will agree with me that if you have something, and this is not just Epic, but any sort of enterprise system of record, if it does 80% of what your best of breed can do, but it's fully integrated, then you'll generally go, or you should generally go with the integrated solution. And an example that I heard of was a system that had a really top-notch population health platform, and they had Epic Healthy Planet. And if you know anything about these software packages, you know the Healthy Planet doesn't hold a candle by itself to a lot of these advanced population health platforms. But it was fully integrated. And what they noticed was that their fully owned healthcare practices that was using Healthy Planet, even though it was a less sophisticated tool, was beating the pants off their independent providers who was using the third-party platform. So what did they do? They basically got rid of the third-party platform, and they forced all their independent providers who were in their ACO to go on Epic's Community Connect.
Great. Good comment. All right, let's pivot now. Let's talk about the movement of the cloud to improve Epic, or are we adding additional complexity? So Yaa, I'm going to direct this to you. Everyone says cloud migration's a big breakthrough, or is it an expensive project that adds complexity and risk for hospitals that may not be prepared for it? What do you think?
Again, I think it's nuanced. The information in the cloud versus on-prem gives you a lot more flexibility, but also introduces a lot of new security risks and vulnerabilities. So you just need to be really mindful about like what the change is and why. But as Epic transitioned from regular hyperspace client and whatever their ancient code was to what is now Hyperdrive, that allows them to have more flexibility in their code and their build to update some of the old archaic tools that didn't integrate well with each other. So I think ultimately, and for scalability, honestly, it just has to be the direction you go towards. But there are a lot of different risks that it introduces, and costs as well, that a really smart CISO needs to be at the table to help take into consideration.
Roy, what do you think?
Yeah, I think moving to the cloud's absolutely where the industry is headed, but it has trade-offs. One is the shift to a shared responsibility model of security. And just because the infrastructure is in the cloud, you're not off the hook. Cybersecurity risks actually kind of scale up, and the impact of a breach can be greater. Here in Hawaii, we have some unique challenges. We're one of the most geographically isolated population centers on the planet. And we rely heavily on undersea cables for connectivity. There's potential latency issues, physical vulnerabilities, either from natural disasters or accidental or intentional damage. So there's flexibility and modernization. Here too, it's a trade-off. And we need to go in eyes wide open.
And Sean, what do you think?
I think all of the above I agree with. The one key element is that, and I think Yaa touched on this a little bit, is that it's not necessarily less secure. It's just you have to worry about a different set of security issues. And I think just generally speaking, if you talk to any CISOs now, they will tell you that actually that cloud migration is actually more secure overall than on-prem. There are all sorts of other gaps that people had to worry about with on-prem that intuitively didn't make a lot of sense, but in reality, a lot of the technical capabilities of having things in the cloud supersede those. And then, like you're just not going to be able to operate now without being in the cloud, because there's
Right.
just so much data. You have to create so much new content. You have to have that nimbleness of not having to deal with your own physical infrastructure.
Great. Thanks, John. All right, let's focus on patient engagement. Are the digital tools making the patient experience better? Hey, Roy, telemedicine, patient portals are everywhere. Does Epic's patient technology make care easier, or is it clunky, confusing, and frustrating for patients? I personally used my implementation at Stanford today, and I find it very frustrating. What say you?
Yeah. So Epic's patient-facing tools like MyChart have come a long way, and they're absolutely central to modern care delivery. But the important thing to realize is the experience isn't quite yet universal. It's improving, and the statistics vary. I saw one source that said about 3/4 of patients in the U.S. were offered access to a portal, and maybe 2/3 of them used it. So that's still a sizable chunk of the population that haven't. And so we need to acknowledge that there is some digital divide that exists, whether it's language barriers, limited access to internet, physical constraints, or just personal preference. And we can't leave those patients behind as care relies on in-basket messaging and self-scheduling. We need to figure out how to incorporate the entire patient population. Some people just want to pick up the phone and talk to someone. And if we design the systems for the most tech savvy, we might be increasing the barrier to care. One thing that can help and that we're looking into is having digital navigators at their organization kind of provide that elbow support and help folks navigate through that digital ecosystem.
John, what are your thoughts? Third-party applications, are they further ahead than where MyChart is today, as we have more of an omni-channel experience? What are your thoughts about where Epic is versus some of the third parties that may give a different end user experience?
And maybe not. I think the bigger issue isn't necessarily the actual technology specific to Epic versus a third party. The bigger issue is just our larger healthcare ecosystem. It's no wonder that Kaiser is a leader in doing a lot of this asynchronous and telemedicine, because they don't have a financial vested interest in getting people into the office so that they can drop the CPT code. And as an extension of that, they also realize that they can likely reduce a lot of costs long term if they do have that very frictionless interaction with the patient. So I think if we could address that, other things would fall into place. And I think Roy's right. Telemedicine offerings by Epic circa 2019 or during COVID were really pretty difficult. I think COVID kind of lit a fire under them a bit, but still kind of clunky. I think that if you had larger volumes of content going through, or larger volumes of encounters going through a telemedicine or asynchronous workflow, Epic's development would go in that direction.
Yeah, what do you think? As a professor, you're helping craft the young minds of our next generation docs. Are you noticing a difference with the earlier generations now that are entering the field of medicine?
Definitely. They're more astute, more tech savvy, and have higher expectations, which I admire them for, and hopefully don't see that deteriorate over time as they become more apathetic once they're beaten down by the process. Just kidding. I think there are a lot of folks that are coming in knowing and understanding just how these tools work, and also having seen other examples of things that work better in different consumer realms, and asking the very clear question, like, why can't my system do that? From a patient perspective and the portal perspective, as a specialist, what John has alluded to, just this like large ecosystem with Epic, when you have patients over like several different areas, being able to easily see documentation and charts and records, like that's something that I think is good, getting better, but still huge gaps there. Like we still use fax machines, y'all. Like it's like, I think there are just so many ways to improve the way that we're sharing information, getting access to information. I'm going to put on my pediatrician hat and get on my soapbox that patient portal access in pediatrics is abysmal. Just like the logistics of like proxy access. And so I think that there are definitely opportunities there. But I know the people at Epic are thinking about this because I have conversations with them and I'm yelling about them all the time about it. So I think it's on like a roadmap. Golly, that is a place where we need to make strides.
But yeah, that's at least as much regulatory and other cultural and governance issues than it is the technology. It's not a small chunk of that issue is just technology.
Just like the notes, like we're married to this process because that's what they require us to do. But I'm like, within the constraints that we are handcuffed to, I can give you 5 ways to build it to make it better. So yes, I would love for us to just like ease off some of the things that are forcing us to work this way, but they could also, alter their code a little bit to ease the burden on our side.
Awesome.
One thing that you said, we recently went live with Teen My Chat that adolescent confidential care, not being a pediatrician, was incredibly complex, and part of it's state and local regulations and that we mired through. But if there is some national way through EPIC as well as governing bodies or professional societies to kind of help standardize that would be amazing.
And you raised something an interesting point where you said that 2/3 of patients were on it. I actually thought that was a high number. I thought that's really good compared to where we were.
Yeah, that was just from a national website, so take it with a grain of salt if we trust the federal government, but it might depend on the polling population as well. EPIC has their own stats on it as well. It could be, what does offer mean? It's available technically, but if no one's ever used it and knows about it, maybe it's lower de facto.
We're going to pivot to our next segment. We talked about patients. Let's shift our focus and talk about hospital leadership and discuss key areas where they should concentrate their efforts. I'm going to direct this at you. What's the most important leadership priority for successfully implementing EPIC?
What do you think I'm going to say, Greg, after all the conversations that I've discussed with you? Governance. Data governance, content and governance of content and capacity. We need to balance out the need to move fast versus the need to create a very reproducible, seamless, frictionless operational and governance platform. It has to be frictionless to the end users, to the clinicians and the patients, but we need to create reduce some of the landmines and pain points that we've actually created for ourselves. So going back to the Navy SEAL thing, slow is smooth, smooth is fast. If you're methodical, think about how when you build something, hey, maybe I'm putting in an ENT physician into the system, I should check this library of specialties and make sure that what I'm putting in lines up with what people have put in before, or fits in with what we've governed as this is what we call an ENT, rather than, I only have 30 seconds to put it in. I'm just going to make up my own term and then I'm done. And the patient, that doctor's in the system. I kid you not, that's probably what happens.
Yeah.
And then the flip side is that I had a wonderful experience with order set governance where we did do a lot of that. And we actually, instead of just taking in all the order set requests, we actually chunked it out so that, hey, pulmonologist, you asked for a pneumonia order set. You know what? It's not your time to get those order sets in. That's not going to be until 12 months from now. And he may jump and scream, but if you think about the content that gets ingested that way, it ends up almost all the time, whatever is an actual rush is almost never an absolute rush. And by doing that, we ended up making order sets way easier to build and ultimately had increased capacity to actually put in this really good content.
All right, let me get a chance for Roy or Yaa. Anything about leadership direction and strategy and approach, that can help improve the likelihood of a successful implementation?
Say learning from other people's mistakes is a great way to save yourself some pain. Like everything John mentioned, taking the guidance from folks that have kind of been through the fire already. We have this wonderful discussion group called SmartServe, where folks post questions about issues they're having, and then we'll have like a flood of responses back from people who've been through similar processes, who have different ideas. So kind of like crowdsourcing ideas is just a really, really important aspect of making decisions, and always asking, like, what are our peer groups doing? Why do they make those decisions? And what's different about us that wouldn't make sense? At Vanderbilt, always need to customize something. We call it like vandalizing things. We just like always have to make it our own. And for that reason, we had a lot of build in the beginning that was just deviated a lot from foundation, technical debt. So I think just understanding like why, like this is better, but like 8 months down the line, when they change their code, you're going to feel it because you have to do work every month to update it, anticipating the next upgrade, and thinking about things like that and talking to your colleagues to make sure they have had to understand what experiences they've had similar to that to guide your decisions, I think has made a big deal.
Before I pivot to Roy, just one question. How supportive is the Epic community nationwide? Is everybody pretty helpful with each other and willing to provide each other with advice and guidance?
I think so. I mean, John is one of my besties, and we all go to user group meetings, and I think just going through it all together as informatics leaders, as people who are practicing, it's just like such an interesting, weird place to be. That being able to have someone who understands like what you're going through, like the difficult challenges you've had communicating to providers about this like change that makes no sense to you either, I think makes for cohesion.
Great environment. Roy, what do you have to add about leadership and strategy and direction?
Yeah, I like sharing this concept that Epic is so intertwined with clinical care. The number one medical device that we use every day is not the stethoscope, right? It's Epic, it's the EHR.
Yeah.
And so breaking down the silos relating to what John said about governance is so important so that we don't have competing priorities between the IT informatics side of things and operations and the multiple wings of operations as well. So breaking down silos is one. The other is that leadership often is rewarded and promoted based on doing new cool things. But the cleaning a toilet, the shared kitchen, as I say often, right? The cleanup, the maintenance, the ongoing training, those are so pivotal as well. And we need to recognize and reward those efforts the same as we do rewarding creating a new program or a new order set.
Great. Hey, thanks, you guys.
Yeah.
All right.
So you mentioned the technical debt. I think, overall, these projects are ostensibly supposed to be led by operational and clinical people. I would say that any organization who puts, say, a CFO or a COO or non-IT person at the head of the table and making decisions on these sorts of things, they need to be required to take at least a 1-hour course on technical debt. And if they don't get any say in decision making.
That's a really good point. Yeah. I see a lot of nodding of the heads there. All right, we're going to pivot to our last segment. I'm going to invite one of you to ask the others a question relevant to today's topic. Who would like to ask it?
I guess that would be me.
Okay, go ahead, John.
So Roy and Yaa, kind of along the same lines of what we just talked about. If you could get in Judy or Sumit's ear and say, look, you're dropping the ball on pushing or developing one thing, where would you direct Epic's development efforts that they're not focusing in on right now?
Would have to say voice. And this is so niche that I don't think they'd listen to me. But I think voice workflows in the EHR 5-10 years down the line are going to be just the most intuitive way we're interacting, getting data in, getting data out on the patient side, not having to learn, graphical user interfaces and any of that stuff. Just be able to express your intent and get information back is what needs to happen. I'd love to see some R&D around making that a thing. And that all falls in the same bucket with Ambient, which they are putting a lot of investment in. But I think like very intentional voice direction of the EHR would be really interesting to see.
Can you elaborate a little bit on what that means to you, just to provide some clarity?
Yes. Imagine Siri that wasn't awful, that worked with Epic. Like you could just say like, hey, what was the patient's last A1C? Or show me a trend of their weight over the past few weeks. Or I would like to see the radiology report from yesterday.
But
yeah.
So I would like to
am I hearing
correct you a little.
A Siri-like interface that might be connected to a ChatGPT-like engine in the background.
So, I think you revealed a little bit of your personal professional bias in this because you completely ignored what I asked of you. They are working on this.
They are working on this, but not to the degree that I would like to see that manifesting.
Okay. All right.
And if I could chime in there, it's a great point. And I've noticed, and this may change, but there's a certain subset of voice capabilities native to Epic. There's another set that they've sort of effectively outsourced to Microsoft, Abridge, etc. And where that line is evolving, but sometimes confusing. And where they rely on third parties, it makes that, we talked about the third party integration challenges. I'm living through the difficulties of implementation and troubleshooting where it's not clear where the problem lies. I think that's something to kind of address head on of what's going to be native.
Is there something else that you would like to see Epic work on that they're not focusing in on right now?
A couple of things. This might be minor, but sort of more uh, best practice for informatics structure. They often, for projects, they give pretty strict guidelines on, you should have X number of, Willow analysts or different types of technical teams. But when I ask for, well, what's the appropriate number of informaticists that we ought to have to make this successful, it's a bit less prescriptive, and appreciating that informatics is very varied across organizations. But if they had something stronger, it might help me negotiate with, the organization to say, this is what we need to be truly successful.
That is so difficult, though, because even at the analyst level and certainly at the informaticist level, the skill sets are so varied. I mean, you have like Metro Health, where like all their informaticists are cache programmers, or you have other places where nobody touches anything other than just be in meetings. It's a little bit difficult to create that sort of benchmarking. So the place that I would like to see them work on is actually related to a lot of the same stuff that we've been talking about before. And you mentioned the smart serve. Imagine if we could take all those years of smart serve and do an like a chat GPT. Hey, or the entirety of all the Different Sherlocks and other emails that they have in their system. I am looking for a rule property that does this. Right now, the reality is that you just happen to have to know. I was just on a call earlier today where I did that. I happen to know 3 different rule properties, and the analyst had no idea that these even existed. Imagine if you could put into an internal Epic system an LLM where you could just say, I want to solve this problem. Here are the parameters. Give me some potential build and some configuration. And oh, by the way, if you want to create some custom cache code, here you go. That last one may be a little bit beyond the pale for them, but the data's all there. But to the point that was made before, the people who do the innovative stuff, like at my organization, there's a big feather in the cap of the executive who's pushing out abridged ambient documentation. But I would say that wouldn't be a similar sort of cachet, no pun intended, to say somebody who was able to make our analyst teams 5 times more effective at building order sets or flowsheet rows or other types of configuration. Now, all of us have enormous backlogs of projects that we want to do. Imagine if we could just clear those out.
Before we wrap up, I want to give Roy one last chance because I know he's been chomping at the bit here. Go, Roy.
No, that's exciting. If I can push that further, this may be a pipe dream, but if I can look into our own system to say, and you need to be on this upgrade level, or you need to have had this configuration and you've deviated from foundation, you need to bring this back to foundation. If it can have that level of insight, which usually we have to ask the analyst for and wait some time, that would be amazing. It might be a pipe dream.
Or to be able to say, give me all the records that we need to edit to get 90% foundation, and what are the configuration things that we need to do. And let me review them and then put them all through Data Courier and put them into production.
Yes, and if you could literally say that stuff out loud with the voice, it would be amazing.
Exactly. Yeah.
Guys, this has been a phenomenal session. You guys have great chemistry together. I really want to thank John, Yaa, and Roy for sharing their knowledge and expertise and insights with us today. Four of the key takeaways I took was strong leadership's required for navigating complexity and driving success. Third-party apps add power but bring risk without the required oversight. Cloud migration opens the door but demands planning to avoid pitfalls. And patient-facing tools have improved but still require kind of a boost to improve usability and engagement. I'm Greg Malkery, host for Beyond the Blueprint. Until next time, keep pushing healthcare forward. You guys are awesome.
Thanks.
Thank you.
Thank you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.